Okay, I also think this is my last time at the podium today, so I want to do two things quick. One is I want to thank Carmen Chinchilla for putting so much legwork into making this conference happen. It's a lot, and I'm really grateful to be able to do this. And then I also want to thank you guys all for being here. Really fun to see so many members of our breast cancer community come together for this, and it's again, just thank you for being here. And now this brings us to Dr. Jonathan Strauss, who's going to talk to us about updates in radiotherapy for breast cancer. Um, Very excited to have him presenting to us today. I think this will be another topic where we're seeing a lot of change and a lot of personalization, and very, very important to stay educated on this. Jonathan Strauss earned an MD and an MBA from the University of Chicago and completed a residency in radiation oncology at Rush. In 2009, he joined the faculty of the Department of Radiation Oncology at Northwestern University Feinberg School of Medicine, where he currently holds the rank of professor and serves as the vice chair of operations and is the director of the breast cancer service. Dr. Strauss specializes in the use of radiotherapy to treat breast cancer. He is actively engaged in medical practice and clinical research. His research interest encompasses many aspects of radiotherapy in breast cancer and focuses on identifying ways to reduce treatment-related toxicities. Dr. Strauss is the author of over 90 journal articles and book chapters. Thank you for being here. Welcome.
There you go, Dr. Thank you. Thank you so much for the invitation to be here. I'm really excited, and thank you so much for the audience for staying all the way till the end. And for a radiation oncology speaker, a quick show of hands is, does anyone here work in radiation oncology? We have one. Wonderful. I know where to look for this presentation, but also it means I want to make sure, I want to do my best to not just speak to those of us who kind of work in the basement, but I want to hopefully make this talk comprehensible to everybody in our medical oncology and surgical world too. And what I wanted to do was talk about essentially everything I thought was interesting and important that came out in 2025, whether in publication or presentation as an abstract. And so this is just a quick overview of the topics that we are going to run through, which is to say, we have new data in DCIS confirming really hypofractionation and the boost. We have updates on ultra hypofractionation or a 5-fraction regimen in invasive cancer. I'm going to touch a little bit on the management of the axilla, although Dr. Myers did such a thorough and wonderful job, I don't have to do too much. Some updates in the treatment of low-risk ER-positive breast cancer from the radiotherapy side, and then really an abundance of data in the setting of lymph node-positive disease for post-mastectomy radiotherapy, regional nodal irradiation. And this is, I think, really everything new and exciting in 2025. So let's run through. And as a quick reminder, when it comes to whole breast radiotherapy, when I trained to do it, everyone got 5 or 5.5 weeks of radiotherapy. And this was what we used to call standard fractionation, and now maybe we'll call conventional fractionation. And we now have 7 randomized trials that compared that to moderate hypofractionation. So 5 weeks versus 3 weeks. And in every single trial, moderate hypofractionation was at least as good. Equivalent local regional control, and toxicity that was the same or better. So really, we all switched. We all moved to a 3-week approach. But there was always this hesitancy, which said, look, all of these trials were really invasive trials. Now, technically, the Danish hypo trial, which is 5 the way down, it had a small subset of patients with pure DCIS. But all of the other trials were invasive disease only. So does this moderate hypofractionation data apply to DCIS? And the second question was the boost. And the boost is, we know that the area of the breast most likely to harbor microscopic cancer cells is that rim of tissue around the lumpectomy bed, right next to what our breast surgeon removed. And so if we want to escalate treatment, we give a little extra dose to that tissue, to the lumpectomy bed. We call that little extra dose a boost. And we have randomized trial data showing that incrementally increasing the dose to that region incrementally reduces the risk of recurrence. But all of these data were in invasive cancer. So, by way of background, here's our biggest trial, which is a Dutch trial that enrolled over 5,000 patients, which is just extraordinary for a radiotherapy trial, and gave them 50 gray and 25 fractions to the breast and randomized them plus or minus a boost. And that boost reduced the residual risk of recurrence by a relative 40%, so cut it almost in half, but at the expense of some additional risk of fibrosis. When we looked when we looked by age in this forest plot, what we can see is that uh, every group derived the same relative benefit, but the absolute benefit depended on what your baseline risk was. So young patients derived a larger absolute reduction in the risk of recurrence than older patients from a boost. That said, these were all in invasive cancer. Does this apply to DCIS? And so here we had the 10-year update to our one big trial asking this question. This is the final update. This is the answer we're going to get, which was a 1,600 patient trial that enrolled patients with what are called non-low risk DCIS, which is almost everybody. You had to be either age under 50 or one risk factor. And they were randomized in a quasi 2x2 factorial design. So 50 gray and 25 fractions versus 42.56 gray and 16 fractions. So this is the moderate hypofractionation question, followed by a randomization plus or minus a boost of 16 gray and 8 fractions. And these data came out exactly as we would have expected, which is to say they mirror exactly what we see in invasive cancer. Moderate hypofractionation looks exactly as good as conventional fractionation, and the boost benefits patients with pure DCIS to the same degree that it benefits patients with invasive cancer, which is to say a relative reduction of 50%. So radiotherapy to the whole breast cut the risk of recurrence at least in half. Adding that boost cuts the risk of recurrence in half again. And on forest plot, every subset of patients appears to benefit. These are all to the left of the line. Now, we might still want to leave out a boost in some patients who are at baseline low risk because the absolute benefit derived by those patients will be smaller, but the boost works in DCIS just like it does in invasive cancer. We move on to this question of ultra hypofractionation. So we've all gotten used to 3 weeks to the breast. What about 1 week? And so we now have an update to the UK Fast Forward trial. So this trial enrolled 4,000 patients and randomized them either to our standard 3-week approach or to two different 1-week approaches, 27 gray in 5 fractions or 26 gray in 5 fractions. And what we found at 5 years was that they all yielded equivalent rates and very low rates of in-breast recurrence, but late toxicity was a bit higher in that 27 gray arm, almost really the same between 26 gray and 40 gray, with ever so slight differences in some fibrosis induration outcomes. So at ESTRO 2025, this is the European radiation meeting, we got the 10-year update to these data. And what we saw was it continues to be true that there was no difference in breast recurrence between these arms. And it continues to be true that 26 gray and 5 fractions looks awfully close to 40 gray and 15 fraction when it comes to late toxicity, whether it is breast appearance, on the patient rating side, breast appearance, the breast being smaller, induration, firmness of the breast, or rarer side effects like rib fracture, lung fibrosis, heart disease, all of which are very rare and not different between the two arms. So this is a 10-year update to the 5-fraction trial. I will say there are many countries in which the 5-fraction approach is now standard for whole breast radiotherapy. In the US, this is still relatively uncommon, at least at my institution. We are now using it routinely for older patients, not quite yet for younger patients, but that's still a big move to go from 5 down to 3 and now down to 1. I'm going to move on to axillary management. And again, I won't stay too long on it because it was covered so well by Dr. Sarah Myers, but I want to mention a few things as we go and then relevant to new data. So, before I was in medical school, everyone with invasive cancer got an axillary dissection, and some of us are kind of familiar with all of the toxicities of that era, but we moved to For those patients who were clinically node negative, doing a sentinel node biopsy and only doing a completion axillary dissection when patients had positive nodes pathologically. And I want to pause here for a second. The sentinel node biopsy is not perfect. It has some false negatives, but we all recognize, and we've done a randomized trial in NSAB PB32, and we found that survival was equivalent, toxicity was much lower. And so even though the sentinel node biopsy is not perfect, it's awfully good, and it is a new way, or it became a new way, to be node negative. And our staging criteria still have us put that little parenthetical SN afterwards. This is a different kind of node negative, but it is a kind of node negative just like our pathologic node negative was before. Let's keep that in mind for when it comes to potentially extending what counts as node negative. So then we moved on to this idea that if you were clinically node negative and pathologically node negative, well, on sentinel node, well, we did observation. If you had 3 or more positive nodes, we did a dissection. But what about 1 or 2 positive nodes? Well, now in the era of trials like Z11, Amoros, Cenomec, we started to say if you're getting radiotherapy, well, we won't do a completion axillary dissection, even though we knew from those trials that somewhere between a quarter and a third of those patients would have an additional positive node at dissection. We didn't need to remove them. The rate of axillary nodal recurrence was still very low without an axillary dissection. And now we are moving on to this question. What about these patients who are clinically node negative, imaging node negative on an axillary ultrasound? Do we have to even do a sentinel node biopsy at all? Or provocatively, is this another form of being node negative? Well, within this question, I want to get at something that was alluded to earlier, which is how much does whole breast radiotherapy influence the rate of an axillary recurrence? And we think about this because anytime we put our patients supine, put our arms up, treat the breast with tangents, when we catch the whole breast, the tail of the breast is intimately associated with the low axilla. So when we catch the whole breast, we are catching most of level 1 of the axilla. Does that show up? If we look at our trials that looked at omission of whole breast radiotherapy and look between the arms, we consistently see that the risk of an axillary node recurrence, while being very low in the arm that did not get radiotherapy, was even lower in the arm that did get radiotherapy. This isn't surprising. When we give 50 gray or its equivalent across the low axilla, do we eliminate microscopic disease? Sure, that's what radiotherapy does, whether it's in the breast or in the low axilla. But we've accepted in any of these trials, so CLGB 9343, most of these patients, this is the trial of women who are over the age of 70 and got endocrine therapy for a T1N0 ER-positive breast cancer, randomized plus or minus whole breast radiotherapy. Most of them had no axillary nodal surgery at all. This trial preceded mostly the sentinel node biopsy. We didn't want to do axillary dissections on these patients. They were clinically node negative. They got randomized plus or minus whole breast radiotherapy. And sure, whole breast radiotherapy reduced an already low risk of axillary nodal recurrence, but we considered that probably acceptable. So let's look at the Ensema trial for a minute, because we're going to see some updates from this trial. And just as a quick reminder, the Ensema trial had 2 randomizations. The first randomization was between observation and sentinel lymph node biopsy. This is, I should say, for patients with T1 and T2 clinical N0 disease who also had a negative axillary ultrasound, or were there any suspicious node that it was FNA proven to be negative. So they were randomized in a 1:4 ratio, observation versus sentinel node biopsy. And after sentinel node biopsy, randomized if the sentinel node was positive, observation versus completion dissection. This is kind of a Z11 question. So this trial has been published, and at least when we look at this initial randomization, so randomization 1, what we can see is, first, that the rate of finding a positive sentinel lymph node was relatively low, 15%. Remember, that's actually relatively low, but it's probably relatively low because we're also, in addition to being clinical N0, they're also imaging N0. And these patients mostly got whole breast radiotherapy, and we saw a rate of regional recurrence that was very low in both arms and not statistically different. The sentinel node biopsy, while being associated with its known and expected toxicities, was associated with no oncologic benefit, whether it be regional recurrence or distant recurrence-free survival. And we saw something very similar in the SOUND trial, which enrolled 1,400 patients who were T1 clinically N0 and imaging N0 and randomized them one-to-one observation or sentinel node biopsy. Again, we saw quite a low rate of positive sentinel nodes, 13.7%. Again, almost all of these patients got whole breast radiotherapy. And again, what we see is a very low rate of axillary recurrence, 0.7% versus 0.4, which was not statistically different. And again, the sentinel node biopsy was associated with no oncologic improvements. And so at San Antonio this year, we saw the Boog 2013-08 trial. And here's why I think this trial, we're going to see why I think this trial adds a little bit to our information base in a minute. 1,600 patients with clinical T1 to T2 N0 and imaging N0 patients all received breast conservation and whole breast radiotherapy and randomized observation versus sentinel node biopsy. Again, a very low rate of sentinel node positivity. But and much like Sound and Ensema, these patients, although they were a mix of patients enrolled, the vast majority of them were over 50 with T1 ER positive tumors. But interesting in this trial is that endocrine therapy usage was actually quite low at 44%, whereas in Sound and Ensema, almost everyone was getting an anti-estrogen. Do we find the same things when the majority of patients are not? And the answer was yes. Once again, we saw that there was no benefit with regard to regional recurrence-free survival or distant disease-free survival for adding a sentinel node biopsy. But our Ensema investigators did a cool radiotherapy question for us too. They said, look, radiotherapy, whole breast radiotherapy was mandated, although it wasn't always used, but let's go back and see how much of the axilla really got encompassed in the radiotherapy field. And they went back, these are the radiotherapy planning scans, and they retrospectively contoured the levels of the axilla using our atlas. So this is level 1, level 2, and level 3, and then tracked how much dose incidentally went to each of these levels. And I would say the results are not surprising at all, but reassuring, which is to say that the median dose to level 1 was almost the prescription dose, around 90% of the prescription dose, which is to say we covered level 1 quite well in our tangents using radiotherapy, which is what we expect. But kind of also as we expect, we got little coverage to level 2 and essentially no coverage to level 3. So the first thing our investigators said was, look, in light of the fact that our rate of regional recurrence was under 1%, while covering level 1 only pretty well, at the very least, we can say we don't probably need any escalation in the coverage of our lymph node basins in light of omitting the sentinel node biopsy, which is reassuring. But then they also looked back and said, not everybody even got the radiotherapy they were supposed to get. What happened with those patients who got no radiotherapy? Not surprisingly, this was associated with a somewhat higher rate of in-breast recurrence. Well, that's what we always see, 4% versus 1%, which for this, at 5 years, this low-risk ER-positive population getting endocrine therapy is actually very much harmonizes with what we see in our omission of radiotherapy trials. That's not surprising. But also what we see is a rate of axillary recurrence that's quite low, 1.2% without radiotherapy and 0.5% with radiotherapy. These are patients who are a mix of people who are sentinel node negative and just clinical and imaging node negative. Again, this harmonizes really well with our omission trials of the past. To me, this is actually, we were willing to accept this in all of our radiotherapy omission trials. We were willing to accept this in our standard partial breast trials. I tend to think that we're willing to accept this in the absence of a sentinel node biopsy, which is to say, I think for low-risk patients, partial breast irradiation is a very reasonable option. I'm reluctant to see our surgeons backing off from surgery and for us to compensate by escalating radiotherapy. I think that if we're in the appropriately selected population where we're looking at omitting a sentinel node biopsy, I think continuing with partial breast irradiation is probably quite reasonable. I'm going to move on to this other de-escalation questions in the stage 1 ER positive breast cancer setting. So we're all familiar with a series of trials that just looked at the clinical pathologic features of maybe age over 50 or 65 or 70, T1N0 breast cancer, getting anti-estrogen, can we skip radiation? But we now have a whole generation of trials that are trying to refine that search by adding a biomarker. We have the IDEA trial, which is a multi-institution but single-arm prospective trial that we'll take a look at in a minute, and the DEBRA trial that are trying to use Oncotype, the precision and expert trials using PAM50, and then a series of other trials using things like Ki67 or a mix of other features, but all trying to add some biomarker to refine our selection of patients for omission of radiotherapy. And we've gotten some hints from these trials in the past couple of years. The Lumina trial, which relies on those clinical pathologic features and a low Ki67, which found a 5-year rate of local recurrence with endocrine therapy alone of 2.3%, which looks even more favorable than our trials based on clinical pathologic criteria alone. We've seen 2-year data from the Precision trial using PAM50 with a 2-year rate of local regional recurrence of 0.3% with endocrine therapy alone, which is remarkably good. We have the IDEA trial at 5 years, which showed a 1% rate of recurrence in the breast at 5 years with endocrine therapy alone, with the single caveat that between years 6 and 7, we started to see a bunch more local regional recurrences come in, and most of us would like to see longer follow-up before we start adopting this regimen. But in 2025, we saw the publication of a validation of the polar assay, which maybe doesn't get talked about very much, but I think is really intriguing. So this assay was initially created on an old Swedish trial looking at the addition of radiotherapy, so plus or minus radiotherapy after breast conservation. And enough of these patients had tumor blocks that could be collected in tissue microarrays that were prepared, that a set of genes related to local regional recurrence were identified, and a 16-gene signature was created. This is the polar assay. And in this study, the investigators then validated this assay looking at 2 other randomized trials where clinical data were annotated and where enough blocks were available to run the polar assay. And it confirmed that this polar assay is both prognostic for local regional recurrence. In other words, patients with a low polar score had a much lower rate of in-breast recurrence than those with a high polar score. But more importantly, perhaps predictive for radiotherapy benefit. That in those patients with a low polar score, there was no difference in the rate of local recurrence between those patients who got radiotherapy and those who didn't. By contrast, in those with a high polar score, there is a large benefit seen with regard to local recurrence for radiotherapy, suggesting that we may have an assay, again, that is both prognostic for recurrence, but also predictive for the benefit of radiotherapy. And we haven't seen a prospective trial of the polar assay like we have for all those other biomarkers, but it has performed awfully well retrospectively. So I think this is something to keep an eye on. And then, just to complicate this picture even a little bit more, all of these trials have asked the question of how can we de-escalate treatment by skipping radiotherapy? But let's back up for a second. Remember, when we asked this question historically, I was giving 6.5 weeks of whole breast radiation. It was a big logistical burden for patients. The burden of care was high. It had a fair amount of acute toxicity. A lot of people got moist desquamation or big skin reactions. It had some late toxicity. We didn't omit the heart from the radiotherapy field or exclude it. But nowadays, none of that is true. We give partial breast radiotherapy in a week. People get grade 0 to 1 skin toxicity typically. Our heart doses are exceedingly low. Maybe radiotherapy is not the thing we should be skipping when we are de-escalating treatment for early stage ER positive breast cancer. So the Europeans tried to do it the other way around, and they ran the Europa trial, which took patients much like CALGB 9343. So these are over 70 T1N0 ER positive patients. They get endocrine therapy, or excuse me, they get randomized between partial breast irradiation in 1 to 3 weeks or endocrine therapy. This is a pre-planned interim analysis at a couple years out. There hasn't been a single recurrence in either group, either arm, but what we do see is substantially better health-related quality of life in the radiotherapy arm, which is not surprising because these patients avoided the typical toxicities associated with endocrine therapy, while the radiotherapy we're giving nowadays is really well tolerated. So another option for de-escalation in these patients may really be partial breast irradiation over 1 week. And having said that, obviously we need to see more maturity of this data set before making a switch. Next, I want to say that what came out in 2025 was a big consensus statement on post-mastectomy radiotherapy that came out of a joint consensus statement from ASTRO, which is the Radiation Society, ASCO, and then SSO, the surgeons, and with people from all three societies involved. And this is my summary of this statement. And I want to briefly walk through this summary. I'm then going to go through a whole bunch of mostly new data in support of where this is and end on this summary again, just so we can kind of uh, really keep this in our minds. So to start with, what are our indications for radiotherapy after an upfront mastectomy? Well, mostly we're going to use it for people who are node positive or have T4 disease. Maybe not if they have either micrometastases or low volume, very favorable N1 disease. We'll get to that in a minute. What about for T3N0 patients or T1 to 2N0 patients? Well, we're moving towards omitting radiotherapy for most of those patients, especially if they have favorable clinical pathologic features. What about if we give neoadjuvant chemotherapy? Well, if they were clinically N4 or clinically N2 to 3, they're still getting radiotherapy. But if they were clinically T1 to T3 and N1, well, then actually, if they convert to N0, we're mostly omitting post-mastectomy radiotherapy for those patients, perhaps with some exceptions, perhaps with a high residual burden of disease in the breast after neoadjuvant chemo or things like it. But otherwise, we're really starting to limit the number of patients getting neoadjuvant chemotherapy followed by radiotherapy. For those of us who work in the radiation oncology world, when we start to get into the tweaks that we do, what's changing? Well, the first thing to say is, what should we include? We should include the reconstructed breast and the regional lymphatics, including the internal mammary chain often, although the consensus is this can be individualized. We're going to look at some data. Moderate hypofractionation is now preferred. So we are at last moving towards where the Europeans have been for a long time, which is post-mastectomy radiation is going from 5 weeks to 3 weeks. Should we boost? We should boost perhaps the chest wall in patients with T4 or positive margin disease, but routinely, probably not anybody else. And when it comes to techniques, often we start with 3D conformal, perhaps IMRT, if we can't meet our goals. Deep inspiration, breath hold to move the heart away and expand the lungs is recommended. Our skin bolus, or raising our surface dose, probably should be selected for just really high-risk patients. So all of this is to say, we're moving towards a lot of de-escalation in the number of treatments, in the number of treatments when it comes to de-escalating the dose from a boost, and um, well, de-escalating the dose from a boost, and in the skin dose when it comes to bolus. Okay, so let's look briefly. This is a table I put together of every trial I am aware of moderate hypofractionation in the setting of regional nodal irradiation or post-mastectomy radiotherapy. And importantly, 5 trials are all confirming equivalent local regional recurrence, with the single exception of the HypoG1 trial, where the local regional recurrence actually favored moderate hypofractionation. But we got even a newer trial in 2025, which is to say the Harvard the Harvest trial, which compared 50 gray and 25 fractions to 40 gray and 15 fractions. We don't yet have oncologic outcomes, but we do see no difference in acute toxicities or cosmetic outcomes between these patients. Just one more trial confirming that moderate hypofractionation looks to be safe in the post-mastectomy or regional nodal irradiation setting. And we saw the SCOGIN-1 trial updated at ESTRO in 2025. And this compared again 50 gray and 25 fractions to 40 gray and 15 fractions. Boosts were allowed to be given sequential or SIB. About half these patients had mastectomy and half breast conservation. The primary endpoint was lymphedema, which was not different between the arms. And also, we see that local regional recurrence is not different between the arms, although numerically modestly favors moderate hypofractionation. The one puzzling thing is that breast cancer specific mortality was a little better in conventional fractionation. This is the first and only trial so far to find this endpoint, and I'm not really sure how to make sense of it. I will say the first author of this trial isn't really sure how to make sense of it either. So we're keeping an eye on that endpoint, but mostly I consider this a confirmatory trial that local regional recurrence and toxicity is not different between moderate hypofractionation and conventional fractionation. What about ultra hypofractionation in this setting? What about using a 5-fraction regimen for post-mastectomy radiotherapy? Well, we have 4 trials that I'm aware of asking this question, and we have really preliminary data from one of them. This is a sub-study of the Fast Forward trial. So I had mentioned it before. This was 4,000 patient trial, but if we look, 496 of these patients also got regional nodal irradiation. And at least an early follow-up, what we see is no difference in lymphedema risk, no cases of brachial plexopathy in either arm, no different in patient-reported outcomes of hand or arm swelling. So we're going to wait for more oncologic follow-up, but these are early data suggesting that we may even be moving towards a 5-fraction approach in regional nodal irradiation. More to come. When we're treating these patients with node-positive disease, should we encompass the internal mammary chain? I feel like we've been talking about this question forever, but there are new data from 2025 to inform our answer. Let's start with what we knew. The first trial to come out was a French trial. It enrolled 1,300 patients who were pretty low risk. Many of them were node negative with medial tumors. They all had mastectomy and they all had radiotherapy to the chest wall, the axilla, and the supraclavicular fossa. And they were randomized plus or minus this little postage stamp to the internal mammary chain. But it was powered for a 10% overall survival advantage. I would love it if a tweak to the radiation field could give us a 10% survival advantage, but that isn't realistic. What they saw was a 3% numerical advantage in overall survival that didn't achieve statistical significance. So is this a negative trial or an underpowered trial? That's really hard to know. We have a very similar Korean trial asking a very similar question, this time in the setting of mastectomy or breast conservation, and again in low-risk population, and again powered for a 10% disease-free survival advantage. And again, what they saw was a 3% disease-free survival advantage for IM nodal irradiation that did not achieve statistical significance. Is this underpowered or is it a negative trial? It's really hard to know when the effect size we powered this study for was unrealistic. So we have two new series, but one of them came out in 2025 that's really interesting. So the Danes did a kind of natural randomization. They had a national policy for how to treat the internal mammary chain. And the national policy in their first study accrued patients from 2003 to 2007. And they just said, for everyone with node-positive disease and a right-sided breast cancer, we're going to treat the IM chain. And for everyone with a left-sided breast cancer, we're going to exclude the IM chain because the heart's kind of sitting nearby. We don't want to raise heart dose. And 3,000 patients were treated according to this protocol. And what they saw was a 3% distant metastasis difference and a 5% survival advantage for having a right-sided breast cancer. Well, either the cancer knows which breast it's in and is behaving differently, or there is something different about the inclusion of the internal mammary chain. So here it sure looked like encompassing the internal mammary chain was an important contributor to outcomes from radiotherapy. The criticism when this study was published was, obviously systemic therapies were old. So they ran the very same procedure from 2007 to 2014 in 4,500 patients with node positive breast cancer. Again, on the right side, they treated the internal mammary nodes, and on the left side, they did not. So there's not really, again, any selection bias. And this time it was done in the era of taxanes, aromatase inhibitors, trastuzumab for those who are HER2 positive. And again, what we saw was the inclusion of the internal mammary chain, or at least treatment of the right side, appeared to be superior. This was presented at ASTRO, or published, excuse me, in 2025. So 15-year distant metastasis-free survival improved by about 2%, breast cancer-specific mortality 2%, overall survival 4% for having right-sided breast cancer in which the internal mammary nodes were included. Most importantly, on forest plot, could we identify patients for whom we could exclude the internal mammary chain? No, at least by number of nodes, whether you had 1 to 3 nodes in the lateral breast or medial breast or more than 4 nodes positive, everyone derived a small but real benefit from internal mammary nodal irradiation. And I do think if we're going to do regional nodal irradiation, we probably should be including the internal mammary chain. But do we need to always do post-mastectomy radiotherapy or regional nodal irradiation? Well, I'll remind us that 3 years, well, in 2022, so now 4 years ago, the Dutch published this multi-institutional prospective single-arm study in which patients with clinical T1 to T2 clinical node positive patients were enrolled. They got neoadjuvant chemotherapy, and then their radiotherapy was determined by response. So those who had a pathologic complete response in the nodes got no post-mastectomy RT, no regional nodal irradiation. Those who were high risk, and those high risk features, so YP N2 to N3, or N1 disease in the setting of a sentinel node biopsy, those patients all got post-mastectomy nodal RT or regional nodal RT. And what we could see was the 5-year rate of isolated local regional recurrence was low for all patient groups, albeit not all local regional recurrences were isolated. So this is a subset of total local regional recurrences, but still pretty interesting. And that leads us to NSABP B51 that it presented at San Antonio a while ago. We finally get the publication in 2025. 1,600 patients with clinical T1 to T3 N1 disease who got neoadjuvant chemotherapy and then were pathologically N0. If they'd undergone mastectomy, they were randomized post-mastectomy RT versus no radiotherapy. If they'd undergone breast conservation, everyone got breast radiotherapy, and they were randomized plus or minus regional nodal irradiation. Although radiotherapy may have changed local recurrence just a touch, that rate was awfully low to start with, and there was no difference in distant relapse-free survival or overall survival or relapse-free survival between the two arms. Radiotherapy was very well tolerated. Grade 4 toxicity was almost no one, but radiotherapy really did not appear to be needed in this patient population. It's important to point out that the vast majority of these patients had a complete response in the breast and nodes. And so really underrepresented was that small subset of patients with significant residual disease in the breast, but a pCR in nodes. On exploratory analysis, there was a suggestion that radiotherapy might have been beneficial for those patients who were hormone receptor positive, HER2 negative, but it's hard to know since these subset analyses are somewhat underpowered. And the last, randomized trial I'll mention that got published in 2025 was the Supremo trial, which is a somewhat confusing trial, but it enrolled almost 1,700 patients of intermediate risk who are treated with mastectomy. So a quarter of these patients had T2N0 disease. These are people I wouldn't normally irradiate after mastectomy. A few had T3N0, and then a lot were T1 to T2N1 disease with a whole blend of tumor markers, although most were ER positive, by no means all. And they were randomized plus or minus radiotherapy to the chest wall only. So this is a confusing mix of patients with an unusual treatment. And having said that, what we saw, though chest wall radiotherapy reduced the risk of a local recurrence by half, it did not change survival. And on the forest plot, it really wasn't clear what subset of patients derived benefit from post-mastectomy radiotherapy. I'm going to ask a quick question before we dive in. Who here has heard of protons? Anybody? Well, a lot of people. If we're doing radiotherapy, should we use protons? Who knows? We have a randomized trial that's asking this question. This is RTOG 3510, or the RADCOMP trial, randomizing patients who are retreating the breast or chest wall and regional nodes to either photons or protons. And we had a presentation on this trial at San Antonio this year I thought was interesting. Very preliminary, but interesting. The primary objective of this trial was reducing major cardiovascular events. So it's not survival, but it's reducing any event. The expected dose to the heart for when it came to looking at the effect size and trying to power this trial, they expected that protons would give a mean heart dose of less than 1. And they expected that photons wouldn't be very good, that the mean heart dose would be between 4 and 9 gray for the photon arm. And that's how this trial was powered. So at San Antonio this year, they then told us, everyone, the trial's closed to accrual. What were the actual heart doses? Where the mean heart dose in the proton arm was 0.88, which was less than 1. That was exactly what they were expecting. The mean heart dose in the photon arm was 2.99, so just under 3. But remember, they expected it to be between 4 and 9. So the mean heart dose in the photon arm is actually much lower than anticipated, which means it's going to be a lot harder to find a difference between these arms because we didn't give nearly as much heart dose in the photon arm as we were expecting. And there was one other interesting finding, which is although the mean heart dose in the proton arm is still lower than photons, the maximum heart dose, the highest dose that goes to a point in the heart, is actually substantially higher with protons. So which is going to be better, giving a high dose to a little piece of the front of the heart like protons do, or giving a higher average dose across the whole heart like photons do? I don't know, but boy, if I had to bet, I think it's going to be hard to find differences when the arms are so close together with regard to mean heart dose, although you never know. So having said that, I wanted to just bring up a little bit of retrospective data to explain what's going on in our consensus statement. And I'll just fly through this, which is, does it help to do a chest wall boost after mastectomy? The best we have are retrospective data. This is one out of the Mass General that, again, suggests even after accounting for known prognostic factors, dose escalation with a chest wall boost, although it hurt cosmesis, it added a little more toxicity, it didn't seem to change local regional recurrence. Neither did this small trial, randomized trial of tissue equivalent bolus, raising the surface dose, at least in most patients. Reduced cosmesis causes more dermatitis, but didn't seem to change recurrence. So that leads us to end on these guidelines again, because I want to reinforce them. We're still using post-mastectomy radiotherapy for most patients with node-positive disease or if they had clinical T4 disease. We're really moving to omit it for those patients who are node negative up front. And we can think of the Supremo trial as pretty good evidence for that practice. After neoadjuvant chemotherapy, we're really moving to leave out radiotherapy for those people who started clinical T1 to T3 N1 and converted to node negative. That we saw the B51 trial that's really suggesting we can leave out radiotherapy for those patients. When we're treating these patients, remember we can move to moderate hypofractionation in 3 weeks, and we're looking at ultra hypofractionation. We probably should be including the internal mammary chain. We saw those Danish data to support that practice. What technique should we use? 3D conformal. If we can't meet constraints IMRT, should we be doing protons? It's maybe reasonable, especially if we can't meet constraints, but we might want to lower our expectations for what that trial is going to show us. We should be using deep inspiration breath hold to move the heart away. We should probably not be bolusing or boosting outside of high-risk things like inflammatory disease, dermal lymphatic invasion, extensive LVI. And I pause there and thank you so much for your attention.
Do we have any questions for Dr. Strauss? Let me check online as well. All right.
Okay, thanks.
Seeing no questions, thank you so much, Dr. Strauss.